Welcome, everyone. I'm Dr. Jessica Seaman, Assistant Dean for Faculty Development in Creighton School of Medicine. Thank you for joining us for our Health Sciences Professional Development today, Cura Collaborative, presented by our Cura Collaborative team. Just a few housekeeping items before I introduce our presenters. This session is being recorded and you will have access to the recording and slide presentation for future reference. We do invite you to ask live questions or submit them in the chat, and we'll get to as many as we can by the end of the session. And we will have an informal panel at the end as well. So if you'd like to save your questions for the panel at the end, that would be awesome. We do ask that you remain muted with video off unless you're asking a live question to assist with the recording. Also, this session is eligible for CE credit, and you'll receive the website and activity code before we conclude. There is a short survey associated with the continuing education, about 4 or 5 questions is all, and we do thank you in advance for providing feedback as we continue to bring you diverse and robust programming here at Creighton. Now, to quickly introduce our presenters, Dr. Hahn Soe-Lin is Assistant Professor of Surgery in Creighton School of Medicine and General Surgeon at St. Joseph's Hospital and Medical Center. Kayla Gray is the Director of the Health Sciences Anatomy Lab on the Phoenix Health Sciences campus, and all of our presenters hail from the Phoenix campus. Dr. Claudia Chambers is Associate Dean for Medical Education and Assistant Professor of Obstetrics and Gynecology at Creighton's School of Medicine. And Dr. Randy Richardson is Regional Dean of the Phoenix School of Medicine and Professor of Radiology. So, Dr. Soe-Lin, if you're ready, I'll turn it over to you.
Good afternoon. Thank you, Dr. Seaman, for that wonderful introduction. So my name is Hahn Soe-Lin. I'm one of the trauma and emergency general surgeons, as well as the clinical simulation director here on the Phoenix Regional Campus. So we're really excited to talk to you today about something called the Cura Collaborative, which we think will be a transformative mindset for the future of healthcare education. An admittedly bombastic statement, but we'd like to share with you a little bit of our programming and hopefully get some feedback and tell you where we're headed and where we'd like to go. And so no financial disclosures, and we'll get started. So for as long as I've known, and many people have in the field of medicine, the general paradigm of medical training has always been see one, do one, teach one. And after a period of observing a practice physician, either cognitively or procedurally or operatively performing something on a live patient, a learner or trainee would then, reflect, think about what they had observed, read about it a little bit, and then the next time they were up to bat, they would do one in mimicking their preceptor or more experienced attending. And by their second repetition, they would basically be taking someone else through that process. So for as long as medical education has been happening in this country, this has been kind of a foundational model for how we take trainees from the inexperienced all the way up to the masters. And when you think about what those masters look like at the time that see one, do one, teach one was invented as a concept, well, it was quite a long time ago. This is a fictional image of Clive Owen, who was loosely based on, basically William Halsted, one of the founders of modern surgery and modern neurosurgery, based on a TV series called The Nick, set in a hospital in 1900, basically at the dawn of anesthesia. And so if you ever wondered what Halsted looked like when he was doing his teaching and coming up with this training model, well, it was the time when the operating theater was an actual theater. Because you really had to see these things to believe them. And the training was both, for the patient, but also for the education and the dissemination of knowledge to others trying to do the same. And so as a surgeon and an educator, I think it's really humbling to remember how much hard-earned wisdom we take for granted currently in our field was really born out of courageous yet spectacular amounts of ignorance and failure. The things that they were considering cutting edge at that time in 1903, 1904, this being at Hopkins in Baltimore, would probably be considered malpractice currently. And so over time, we wondered, we noticed where our general surgery trainees where or weren't, and historically hanging out in the operating room, soaking up every bit of education you can from the seniors and attendings around you was the culture of the surgical training program. And we found over time that we noticed less and less our junior trainees having that opportunity to come into the operating room and learn with us. And what we realized in modern times was that where was everybody? Well, this is with the villain from The Incredibles 2. He's called the screen slaver, and his thesis was that everyone's been enslaved by screens. And even though he was a villain, he was not wrong. And when they measured this out, they found that surgical residents were spending a considerable proportion of their time in front of the electronic healthcare record as opposed to in the operating room. When they actually put a clock on their EHR systems and measured this in high fidelity, this was 2,512 continuous hours in front of a computer screen, 8 months over a 5-year training period. This is not just an infliction of modern times in the general surgery world. Internal medicine residents doing very similar feats of electronic documentation in substantial portions of their care and their training time. So not at the patient bedside anymore as we would like and as we would espouse in our medical education, but sucked into the electronic healthcare record as a challenge. And so when we look at the paradigm of see one, do one, teach one, between the increasing demands of documentation paired with the work hour restrictions, and really the broadening patient expectation and medical legal sensitivity about learner autonomy, we realized that the concept in the paradigm of see one, do one, teach one really did not fit the modern medical healthcare education paradigm. And so, we thought we needed to explore what we could do to bridge that gap. And others have in the country. Foundationally upon this concept is the uncomfortable truth of all of the practice of medicine, which is that no matter how hard you work, no matter how many textbooks you read, no matter how many YouTube videos on a procedure you see as they do now in 2022, one day you're the one holding the knife. You're holding the breathing tube, you're holding the scalpel, and you have a patient's life in your hands, being called upon for the first time to perform a procedure that is either painful, uncomfortable, or carries risk or harm to the patient. And medicine is actually unique in this high acuity professional practice in that our field is really the only high reliability profession where a substantial proportion of the practice and the actual performance occurs on the same platform. And that platform for us is a live human patient. And just to draw a few examples of how hard it is to bridge that gap, the current real best available simulation platforms out there fall dramatically short of the complexities of the real human body. This is a $100,000 sim mannequin meant to simulate trauma. It's going to be strapped onto a live patient actor. You can do everything from a chest tube to a full-blown laparotomy. It was developed for military training for their combat medics and such. And even though it's a very sophisticated tool, at the end it really very much looks and feels like some of the plastic mannequin dolls we've seen in the past. And so we are the only profession that has to practice with this type of platform and then go out and perform. And, as an example, you would never give an NBA player like Steph Curry a basketball set that looks like this and then have them step into an NBA game and hit a buzzer-beating game-winning jumper with millions of people watching. The metaphors go on and on. You would never give Captain Sullenberger a training set, Fisher Price, that looked like this and expect him to land in the Hudson with 155 live souls on board his aircraft and no engines. Other high professional, high reliability teams, this is the Red Bull pit stop crew. That's the 1.9 second world record. Tire change happening at 70 miles an hour going into that pit stop. They're not practicing on Legos. And if we look at the team dynamics of how those teams, high functioning, operated, it's with a tremendous amount of precision at a tremendous amount of difficulty, and they train on the real thing every day. And when we look at our trauma bays, which start to resemble pit crews, when you have a high complexity trauma, in a very critically ill patient, it's a very different, very unintentional, very disorganized training paradigm that we have to deal with. So in 2022, where do we take our trainees? This is the best model we have available for a chest tube in modern times. And then in every July, we send them into the real world of the trauma bays and the real war zones of the urban gunshot wounds and have them take care of the patients. We work our medical doctors on simulated platforms like this, and then we have to put them into the real overcrowded ERs and have them execute patient care under very, very challenging circumstances. CPR mannequins getting more sophisticated by the year. These are the best available ACLS trainers for advanced cardiac life support. It's the real thing, a very challenging and very difficult experience to execute that type of complexity of patient care in real time. So in particular, things are not always easy to simulate. This is the best available intubation mannequin for placing a breathing tube with someone with acute respiratory failure. It's plastic. The fidelity of it is not great. And as we found out during the COVID pandemic, a lot of people had respiratory failure, and we lost a lot of clinical folks, either due to retirement, due to attrition, due to the stress of the job. And if you look back at the paradigm as to who was supposed to be intubating these critically ill patients in the middle of the COVID pandemic, well, they said it was the most experienced airway practitioner should be the one taking on these high-risk airways. And then if you look at the reality of it, I look at this patient who was published in the New York Times with their associated emergency room resident. This is an intern in about April 2020. And if you look at her eyes, I've seen that look many times in early training. I've had that look on my face many times, trying to deal with something that you realize all of a sudden perhaps you were slightly ill prepared to take on. If you look at her eyes, she is a million miles away from that training mannequin. And so, we've come to kind of a tipping point in the medical world where a substantial amount of clinical expertise, hard fought, hard earned over the years, is going to retire, is going to leave the field. And I think the need to rapidly and safely train a new generation of healthcare practitioners and arm them with greater experience, with safer experience, has never been greater in modern times of U.S. healthcare history. So in high reliability professions, I don't mean to say the Red Bull team gets it right every time, right? When they don't, all sorts of things can happen. But in clinical medicine, when things don't go right, the results are devastating, right? This is a trauma bay from a young teen that was shot at Temple University in Philadelphia. This was published in the New York Times several years ago, and this is what we have to deal with, the messy complexities of practicing medicine and surgery in the real world. So we asked ourselves, is this the best that we can do to prepare our trainees in 2022? And that's sort of the thesis upon which the Cura Collaborative was founded upon. And really what our vision is a mindset centered upon providing all healthcare learners in this space with hyper-realistic simulation education, with the 3-point goals of improving learner performance, improving patient safety, decreasing healthcare costs and outcomes, and using all of this to serve our communities via data-driven research. We had 2 core philosophies that really found the program. One is that students really need the space to fail safely and learn from their mistakes, but they need to do that in an environment that doesn't risk patient safety. And the second piece of our philosophy is that in contradistinction to the somewhat unintentional random approach, the mud against the wall, so to speak, of medical education that's been existing for so many years, intentional clustered repetitive practice, whether that's cognitive practice and simulation or procedural practice or both, really rapidly accelerates student confidence as well as confidence in tackling these problems that they're going to have to face in the real world. So our program has been a long time in coming. As you can imagine, there's been a lot of administrative, ethical, legal oversight that's gone into thoughtfully developing a complex program like this that also involves cadaveric full body donor training. And so we've been in proof of concept for about 15 months and have been recently funded for a 3-year pilot to measure the impact of this educational platform and really kind of articulate how far we can take a learner when we give them the autonomy that they currently lack in their modern educational space. So there's been quite a long process around that, certainly an ethical directives review with senior leadership from both our hospital system here with Fisher Margaret McBride, as well as multiple ethicists, as well as religious leadership from Creighton University School of Medicine. And it's important to note that, we have a steering committee that really vets any procedural simulation that we're doing on a donor cadaver. And, these are reviewed by a group that's not just surgeons, not just physicians, but really multidisciplinary to make sure that we're approaching everything in a thoughtful way. So no procedure is done on this platform without a voted approval from this interdisciplinary, interprofessional committee. From a safety standpoint, these follow national whole body donor company best practices. So that includes serology screening for all common bloodborne transmissible pathogens. And one of the keys to this program is that we partnered with a technology company that developed a novel non-formaldehyde preservation solution. We'll show you what that looks like as pictures and videos are worth quite a few more than words. So from an infrastructural standpoint, this program exists at the junction between the clinical academic partnership of the Creighton Health Sciences campus in Phoenix, the Creighton Alliance residency program, and then its affiliate clinical hospitals at St. Joseph's Medical Center, as well as Valleywise here in Phoenix, Arizona. It is pipelined by the development of a whole body donor program. Again, in order to bring high fidelity procedural training, we have to get out of the plastic mannequin space and work on actual decedent human donor bodies. Where this happens is a variety of locations, including the Health Sciences Campus Anatomy Lab, as well as at the hospital, both in our OR and simulation space. We have engaged Cypher for interprofessional programmatic support as well. So this is sort of the component stakeholders in the program, with a contribution from St. Joseph's Hospital in terms of space, OR equipment, staff, in order to build this complex program. We're very excited that our partner Valleywise, another part of the Creighton Alliance, is going to have a brand new simulation center coming online, probably within the next 5 years. And of course, all of their faculty are Creighton Alliance faculty, teaching both the residents as well as the students. The residency itself, this spans both procedural and less procedural specialties. We've actually realized that there's something for almost every residency program here, with the exception perhaps of psychiatry, in order to provide platform opportunities for extraordinarily high fidelity training. So we're going to show you some images, and this may take people back to their first year anatomy labs, which hopefully people remembered or maybe have tried to forget. But everyone remembers the smell. The formaldehyde preserved cadavers that formed the basis for a first year anatomy course across the country really looked like this. And as surgeons, we realized that our trainees or medical students have to come to their third year, fourth year clinical rotations and relearn it all over again, because what they had learned in their first year in no way, shape, or form resembled the tissues of a live patient. When we look at cadaveric training, certainly this is a look at sort of the forearm with a dissected hand as well. And again, the formaldehyde preservation certainly desiccates the tissue, it stiffens the tissue, and that makes it extraordinarily hard to bring clinical reality into that space. At the graduate levels, there's been sort of fresh or wet cadaver labs throughout the country that do procedural training, surgical training, things like this. And you can see the tissue fidelity certainly improves. But the time frame over which you can use these is very short before decompensation sets in. And so everyone's done a weekend course, once a year for surgical or procedural training somewhere in this country, but you can't really build out a longitudinal training program around that. This is a case report of a live human patient. So this patient had a compartment syndrome, a limb-threatening problem of their forearm. And so they required what's called a fasciotomy, which is a release of that compartment pressure in order to save their limb. And you can see the muscles, tendons, tissues, certainly in broad contradistinction to what the students get to learn about these same structures in their first year of anatomy. Under best real-world circumstances, this is Global Anatomics, also known as GAX. That's the technology company that developed this non-formaldehyde preservation solution. This is a donor cadaver that has passed away, 1 or 2 weeks before it came to our lab. And we have a preservation model where we use expired packed red blood cells from our hospital that otherwise would have been discarded. But this is the type of tissue fidelity that we can now bring to the learners, and the procedural and operative opportunities that this platform then affords got us really excited about what we could do for student education. So we looked at a few test case scenarios as to what would be most impactful. Chest tubes are near and dear to my heart as a trauma surgeon. I have to take residents through this time-sensitive, life-saving procedure every July. At great stress to both myself and the residents, and probably the patients if they're awake. But if you look nationally, 1 million of these chest tubes are placed in the country every year. And even for a procedural specialty such as general surgery, which self-selects procedurally interested, technically competent trainees, the complication rate is 7%. And this is a procedure that spans multiple specialties. If you work in a medical ICU, if you're a pulmonologist, anesthesiologist, if you work in an ER, someone comes in with a collapsed lung and it's going to be on you. And if you look at the complication rates for those other specialties, they're even higher. So it's a short procedure. It's a simple procedure from our perspective, but if you actually map it out, it's quite complex, and there's many opportunities for failure and complication, having to bluntly enter into the chest next to someone's heart, next to their lungs, has all sorts of opportunity for inadvertent injury. And so what we did with our students who would otherwise have never allowed this opportunity or be allowed this opportunity on a live patient is we wanted to see where they could go with a set of clustered repetitive training opportunities. So these are 3rd and 4th year medical students, Creighton, performing chest tubes. And if you look at their eyes, they start to look a little bit similar from that resident in the real world having to intubate a crashing COVID patient. But what I like about this photo is that you can really see the student integrating a lot of information at the same time. They've made a dissection sharply into the chest. They think they're in the pleura. They have their finger in the space between the ribs. And that student is trying to decide, did I make the hole big enough? Did I make it in the right spot? Is my finger where I think I should be anatomically? And can I put this life-saving chest tube in safely through the hole that I just made? And there's a level of integration there that I only see on the faces of residents performing this actual procedure on live patients. And I never see this level of integration, cognitively speaking, on patients trainees learning to do this on a simulated plastic mannequin. The fidelity just isn't there. And so when we measured the performance of 4th year medical students performing 6 repetitions of a chest tube, what you see here are box plots of their times, and the spread between the slowest and the fastest 4th year medical student on the first repetition is extraordinarily diverse. But as they perform more repetitions, the band becomes very narrow. The slowest students start to approximate the fastest students in terms of their procedural performance. And when we measure this against the standard, which would be surgical residents who have gone through unintentional, sporadic, non-clustered training of chest tubes, basically being allowed to put in a chest tube whenever one was available if they happened to be on the rotation that allowed it, these 4th year medical students started to perform at the level of surgical residents in their 2nd and 3rd years of training. And when we retested those medical students 4 months out from their initial clustered training, we also found that their performance was very similar. So we demonstrated that there was durability, at least at the 4-month mark, to the muscle memory that we had developed in these students for this life-saving procedure. So we published this at the Association of Surgical Education as sort of a pilot study of what intentional clustered procedural practice could do. And we were surprised by how quickly the students got better. I initially thought that they would need 20 repetitions of a chest tube, and really after just 5 or 6, they were getting pretty fast. So we brought this to our Creighton Alliance surgical residents at their boot camp this past July, where the students are getting through their hospital orientations. We gave our 15 PGY1 surgical interns the opportunity to perform repetitive intentional cluster training with chest tubes and other procedures. And it was quite remarkable how similar the stories were. And in fact, instead of needing 6 after only 3 repetitions, the performance and the spread of heterogeneity of performance between the first-year residents got narrower and faster very quickly. So we published that as well. But I'd like to show you a little bit about what that looks like in video. This is just a brief clip. And what's important is that the first part of the video is really a third-year medical student doing a chest tube for the first time. And subsequent to that is one of the fourth-year medical students doing a chest tube for, I think, the 5th or 6th time. And you can really see the change in the confidence with how they handle the instruments, with how they handle the scalpel. And what was very striking to us was seeing that 4th year on their 6th chest tube repetition, they really looked like our chief resident. They looked like our attendant. There was really an economy of motion and efficiency that was absolutely spectacular. And it's hard to explain if you don't do this specific procedure for a living. So in terms of taking a scalpel to live skin, this is actually probably the first time that Tyler has ever had this opportunity. And you can see the fidelity of the tissue in terms of, the tissue turgor. That fluid was not fluid we had put into the chest. That was just fluid that was there. This is the 4th-year student. I'm not sure whether the video bandwidth will keep up with this, but you can see every hand motion has a purpose, and there's really no wasted motion at all. So that's just a brief clip of what we thought was a window into the potential and the possibility of clustered repetitive training. So as we expanded this paradigm, we realized that there was very little that we couldn't do on this high fidelity preserved donor. And over the course of about 12 to 15 proof of concept sessions at our St. Joseph's Hospital OR, we brought a tremendous amount of surgical and procedural learners into our space. So on the left, you can see there's one of our chief residents who is going into vascular surgery. She's performing a carotid endarterectomy. There's an exploratory laparotomy of the abdomen happening concurrently. On the right, one of our residents who's interested in going into cardiothoracic surgery is actually doing a heart and lung explant with some of our cardiac surgery faculty. Over on the left is more of that procedure. On the right, you can kind of see the amount of interest and enthusiasm surrounding these opportunities. The medical students getting to sew on basically the closest thing to live human tissue you're ever going to see, and certainly very far away from the felt pads that they're typically training on. This is a mastectomy, so that's basically a surgery for most commonly breast cancer. And we started to realize some of the things that you just couldn't do in a live OR space that were educational. An axillary lymph node dissection, which is frequently accompanying this surgery, has a lot of steps, has a lot of complex anatomy, has a lot of opportunity for injury. And our faculty from Valleywise just brought a picture. This is her teaching picture that she kind of goes through the students with as to the anatomy, and they just taped it to the OR pole. You would never be able to do this due to the sterility considerations in a live OR, but when the resident and the student got lost in the steps of the surgery, well, they just looked up at their map and they had an instant reference that they could kind of refine their way. We started realizing that other surgical specialties also had similar training challenges to us. So the gynecologists having to do laparoscopy, certainly increasing challenges in training their residents at scale. This is our section chief paired with a 4th-year resident doing what's called a laparoscopic adrenalectomy. That's a surgery for removing a tumor or a mass of the adrenal gland. If you're a high volume surgeon in this country, you do more than 5, probably no more than 10 of these a year. As you can imagine, training that and practicing that, even at the attending level, is a massive and ongoing challenge for practice readiness. This is Dr. Andrew Keenahan, one of our fourth-year residents who had the opportunity to do 2 on that day because there's a left and a right. So he's already had 2 of these high-fidelity laparoscopic adrenalectomies under his belt in one day. Pretty much anything on the platform you could think about is available in high fidelity. So our neurosurgery team got involved. This is an intern, a first-year neurosurgery resident, being able to do a craniotomy for the first time. So he opened the skull. You can see the exposed brain on the surgical field on the left. In the middle, we have a thoracic spine surgery, and you can see them putting the hardware in there. This is some photography from some of the trauma demos, and you'll see some video of that in just a moment. So when we look at the aggregate of what the program has been able to achieve, and things that are highlighted in blue here are non-surgical. So this has both procedural as well as operative training opportunities. The sky's the limit. I mean, there's almost nothing here that we thought about that we thought we couldn't do that we found out we could when we tried. And so in aggregate, we've had about 400 learners now track through the program. That's included residents, that's included medical students. We've even included nursing students instead of some of our CPR demos in high fidelity. As you can imagine, a donor cadaver is an excellent analog for a patient in cardiac arrest. And we've completed over 70 different operative or otherwise technical procedures, both at St. Joseph's Hospital as well as at Creighton's Health Sciences campus. So looking back at where this is going, we're currently funded by the Flynn Foundation, a local philanthropic organization, and they've given us RAMP for a 3-year pilot project in order to scale the program, to acquire more donor cadavers for training, and to basically increase the cadence of training and measure the impact of training for students and residents here at the Health Sciences campus and through the Creighton Alliance. And when we looked at how much training we could get out of X number of donors, our first pilot year with 30 donors is anticipated to have 400 to 500 operations and/or procedures. And by year 3, we'll probably be bringing between 800 and 1,000 total operations or procedures to the trainees here with absolutely no impact to patient safety. And so I wanted to show you just a few videos, again, if the bandwidth will keep up here, as to what this looks like now in its current rendition. And what we really wanted to do was get away from the feel of a cadaver lab where you had 15 students hovering over one cadaver, vying for procedural opportunity. We really wanted to mimic the training environment that the students and residents are exposed to in a real live patient setting. And so, what you'll see here is our simulated OR, and we've really taken great pains to make it look and feel and sound like an actual operating room. You'll see a vital sign monitor up there. There's no heartbeat. It's completely simulated. These donors are definitely dead, and they have been for weeks. But it's an idea of sort of how the look and the feel of it kind of goes if you're able to see this. And so this is, like we talked about, the laparoscopic adrenalectomy that Dr. Keenahan had the opportunity to perform. You can see on the monitor the quality of the tissues here. This is done without bleeding perfusion, so we're not actually perfusing any red blood cells into this donor. This is native fluid. And Dr. Keenahan is performing a very tenuous part of that dissection. On the top left of the screen is the spleen, just deep and inferior to where his instruments are is the kidney. Both of these have massive opportunities for life-threatening hemorrhage that he is just a few millimeters off of his mark. And so for an operation that most attending surgeons only get to do fewer than 10 of, excuse me, a year, wouldn't it be nice to be able to tell a patient's family that the surgeons that were doing this procedure have been trained to the standards and the quantity and the volume of practice that we expect of our concert pianists, of our NFL and NBA basketball players, and of anyone else in the variety of different professional settings. This next demo, this is the neurosurgery team. So they are doing a spinal fixation surgery. What you see here, that same shaky for third-year student who was doing the chest tube for the first time, he is now interested in neurosurgery and is on his research year with the neurosurgery department here at Barrows Neurologic Institute. And he is for the first time having the opportunity to participate in an operation on the spine. We didn't film all of the parts of this because the residents are also having a blast exploring this platform. But he had the opportunity to perform part of this dissection. And again, this is something that would just never be an opportunity for a trainee on a live patient due to the risk. This next demo, this is showing our gynecology colleagues here. And so they're doing a laparoscopic hysterectomy with a retroperitoneal dissection. Again, this is sometimes done for tumors or other benign pathologies. But you can see at a slightly higher ratio of learners to patient, there's still the opportunity to train large volumes of people. These are all of the interns in the gynecology team, as well as some of the medical students who were on the service with them. And they all had opportunities to participate in the dissection, put in the ports, help out with the equipment, do the suturing afterwards. So there's a lot of training that can happen. And you would never let 5 or 6 people up at the table in a live OR. So these are a little bit more invasive. And again, I don't have the full sound here, but maybe part of it. This is one of our trauma simulations. So this would be a critically injured patient having to, maybe have multiple penetrating wounds to the chest and abdomen, a really high acuity, life-threatening situation. And so this is really the full spectrum of what a level 1 trauma center is built to do. And the residents having to participate in this have a very short leash in real life. The attending is going to take over if the patient is crashing because the resident doesn't have the skill set to perform things quickly enough. But here what we have is a second-year resident opening the left chest for the first time in her life. And if she's doing this in real life, he's got about 2 minutes and 40 seconds to get down to the heart and cross-clamp the aorta to stop bleeding distal to the chest and the abdomen. You can see the lungs inflating in high fidelity because we intubate these donors and hook them up to a positive pressure ventilator. This is with our full bleeding simulation as well. So you can see kind of the blood coming out of the lung there. And the resident scissors right now are about 3 millimeters from the anterior border of the heart. And they have to open the lining called the pericardial sac here. You can imagine having shaky hands or not knowing exactly where you're going carries tremendous risk at a very sensitive time. And she is doing this for the first time. And even though she's read about it, applying the steps kind of like following a recipe. When you actually have to apply the steps in the real world, they don't always match the directions provided. So what we find when we look at these simulations is that the residents make all of the small mistakes that they do on a live patient in real time, and they learn from them. That resident didn't make the hole in the pericardium large enough to deliver it. She didn't cross-clamp the aorta fast enough. She wasn't making the incision broad enough in order to get the access and exposure she needed to do what she needed to do for that patient. And these are games of inches and millimeters. And so you just can't do this. You can't do this on a porcine model. You can't do this on a plastic trainer. And all of those mistakes come at a cost. All of that learning comes at a cost. The cost is not getting to the critical steps of that procedure in a life-threatening situation for an actual patient. This is the second iteration of that trauma demo. So we're already sort of scaling things. And what you can see here, this is a more experienced resident now standing at the left chest. They've already got the chest open. And here they have the opportunity to repair a complex lung laceration, again, on a moving target because that lung is ventilated and expanding and contracting with the ventilator. And what we see there is not only that this resident has more technical experience and fidelity, they can throw the stitches faster, their hands are a little softer, they're not tearing tissues with their adrenaline up, but managing all the rest of the operative field, this resident has actually completely forgotten that we have told him there's heavy bleeding in the abdomen that needs to be addressed. And so, they're getting horse blinded into the technical steps that they have in front of them. The cognitive process of then learning how to manage all of the pieces of that patient's care in the operating room are automatically taken over by the attending in real life. But here we can just let that happen and remind him after he's thrown a few stitches, hey, what are you doing about the bleeding in the abdomen? And he realizes, oh my goodness, I've completely forgotten. And that's a lesson that you don't want to learn at the bedside with a live patient, but unfortunately, in the absence of a platform like this, historically, we've had to. And so where do we go from here? Having sort of seen a small window into the opportunities afforded by this platform, well, our goal is really to provide a world-class training platform that fundamentally alters how surgical procedural training is conducted in this country. There's a heavy pedagogical lift to that, demonstrating the amount of training, the amount of repetitions, the amount of intentionality required to bring an early trainee up to speed in a way that impacts patient safety or other endpoints is a huge challenge, but it's a challenge that we're excited to take on with the support of Creighton, the hospital here at St. Joseph's, our partners at Creighton Alliance, and of course the Flynn Foundation. And so with that, I'd like to leave the last 15 minutes perhaps for questions, and happy to take any feedback or any ideas to help continue to grow the program. Thank you very much.
So we'll do a little Q&A session with Dr. Chambers, Dr. Richardson, and Dr. Soe-Lin. I have a few questions keyed up, but if you guys have any that you would like to add, please do so. The first question, Dr. Seaman, did you have something to add?
Yes, I've already received one in the chat, and it goes right along with some of the videos that we just saw. Are you needing to pump fluid into the body, or is the fluid already there? Is it the original fluid that was there in the body?
So there's a preservation process that expels all of the existing human biologics, so your blood and your fluids in there. So there is a solution there. For the bleeding model, we use expired PRBCs, and we use a roller pump to pump the blood throughout for some of those videos.
Thank you.
There's a question in regards to how do the participants say the tissue feels?
Maybe Hahn should comment, yeah.
Yeah, we've certainly surveyed the learners in terms of the tissue turgor, as they have in other studies, with light preservation techniques for improving fidelities of cadaveric tissue. And so anecdotally, as well as on the surveys, certainly the tissue quality has been widely regarded as close to lifelike as you could possibly get. And certainly at the resident level, the student level, and the attending level, that's been a fairly universal theme. We did debrief and have a debrief process with our earlier learners, because we realized that as we were exposing preclinical students into this space, of course, this hyper-realistic environment is something we take for granted working with live patients every day in an operating room, but making sure that the students also were able to process the emotion of it, the feeling of it. We brought our humanities faculty with Nicole Piamonte and Dr. Zarulnik as well. And it was very interesting to see that the perspectives are, from an emotional standpoint and a humanities standpoint, are as educational, I think, for the learners as the operative and technical aspects of it as well. Certainly bringing sort of grounding, the why of why you're going through your anatomy class becomes much more real when you kind of see the clinical import of that at a much younger part of their training.
Maybe Claudia could comment on it too, just from an OBGYN's perspective. What's the tissue fidelity like?
Oh, the integrity of the tissue was phenomenal. I think for us, when we did our hysterectomy as a team, some of the benefits were, one, that we had, again, early residents, so interns and the like, being able to do high-risk procedures like you had mentioned, and doing some of the things that you as an attending would be uncomfortable having them do in a very, very calm setting. Multiple people were able to be exposed. And I mean, you really could not tell the difference between a live patient and an expired and the donor. It was pretty spectacular.
So kind of on that note, if any of you have any thoughts on this, what are some of the feelings that you have on how this program could help shape the future of medical education?
I guess I'll jump in. I really think of the Cura project as kind of a leap forward in medical education. And that's true across the disciplines. It is really allowing us for us to do these high stakes training in low risk environments, leaving us to create an environment that is optimized for learning. It, to me, is the flight simulator for medicine. It really allows us to do these hyper realistic trainings. And it does something that we've never had before. It allows us for early and sustained competency. And I don't think we've had any tool that has allowed us that same level of experience. I think of the Cura project as the red thread or the continuum of medical education. We get early procedural competency with our students. We get accelerated residency mastery. And then for me as a clinician, we see this prolonged faculty competency and adoption of even new skills and innovative skills as a result. And at the end of the day, that translates to patient safety, and that's what matters most.
I don't think innovation can be understated here or overstated. It is such a platform where you can innovate without hurting someone. I've been doing cardiac imaging for a couple of decades now. We did a few air injections into a cadaver, and I have never seen cardiac anatomy as well as I saw it on one of these platforms. It is spectacular, and that opportunity to innovate just isn't there in the real life setting, because you don't want to experiment on a person that's alive. But in this situation, you can innovate. And I've heard lots of ideas about things that our faculty want to do. And I love the enthusiasm. I love the innovative sort of spirit that's going on. But just like Hahn said, there is a process that you have to go through. And we want to make sure that we stay in control of the process. We do want people to innovate. We do want this opportunity to have these real life experiences, or as near to real life experiences as you can have. But we do want to go through the process, go through the committee, make sure that we are giving our stamp of approval on anything that we do on this platform.
We do have a couple more questions that were sent to me in the chat. One of them is, do we have any opportunities for IPE training with our current student disciplines? Do we have any coming up?
We currently don't have any plan, but we do have, we already have the process approved through CIPER. So when we are in the process of planning those, that'll be something we'll work with our CIPER group to move that forward.
This is something that's actually of particular interest to me, because working in a trauma bay, it's a very interprofessional space. You have not only the trauma surgeons, the anesthesiologists, the ER nurses, the respiratory techs, the X-ray radiologists, the big team that has to take care of a high acuity patient. And so when you think about other crisis resource management scenarios, most commonly cardiopulmonary arrest, we've trialed this. We've actually done interprofessional training with both the nursing students, the internal medicine residents, medical students who are on anesthesia, as well as the surgery residents. And, you know, everyone goes through their basic advanced cardiac life support training, and they learn how to do compressions, and they learn, you know, sort of the workflow of the algorithm. Applying that algorithm in a tight space with 15 people in the room surrounding around a patient is an amazing thing to see when it's done well. It's a tragic thing to see when it's done poorly. It doesn't always go as well as you'd like in the messy world of live clinical medicine. And so we've put them in that emotional space where the chest compressions feel real, where you actually have to get that airway under duress, where no one can get an IV, so they have to go to plan B. And, you know, the pharmacist is yelling across the room for the dosing of the medications or the medication doses, right? All of that is really part of what we consider to be the thesis of the Cura project, which is that this high fidelity training has to happen with all of those other components in mind. It's not just reading the textbook. It's not just knowing the algorithm of the medicine. It's applying it in the real, or at least as real of a world as we can make it without the patient safety risk. So those interprofessional opportunities are certainly things we've piloted and are looking to expand upon greatly.
And I feel like we have a unique situation here at this campus where we have so many disciplines that really can work together. So that's great that you've already been doing a lot of that. Another question that I have here is, do these kind of procedures count towards residency requirements, or is that a hope in the future?
It's a great question. We're certainly aiming in that direction. And I think, you know, if you look at the ACGME requirements for a loggable operative case, it's not only the case, it's also 50% of the perioperative care around that. And so that really leads us to a broader talking point in that, you know, what we highlighted here today is really sort of the procedural side of a broader thesis. And if you really think about what intentional clustered repetitive training and education means, it's not just procedural, it's cognitive. And so, you know, can the resident now have a standardized set of post-operative complications or preoperative, you know, medical considerations that informs the decision to operate, and how do they manage that? That part is actually easier to simulate. It's really hard, as you could imagine, bringing a cadaveric training program across a Catholic institution with a Jesuit, you know, associated medical school and all of the administrative oversight that goes with that. But the cognitive aspect, the idea that, you know, if you're on an internal medicine rotation, you show up for 6 or 8 or 12 weeks and have to rely on whatever patient pathology randomly is in the hospital ward on that time, is something that we can actually improve upon in the simulation environment. High fidelity medical ward simulation is actually much easier to execute on. And so we're absolutely thinking about filling gaps in, you know, operative log cases that are hard to come by or very rare in the real world. The lap adrenalectomy is a prime example of that. But we have to build out the simulation for the rest of the pre and post-operative care in order to get there. And I think we will eventually.
We've got a great question here from one of our students, and I think Dr. Richardson or Dr. Chambers might be able to answer this. But do you see this changing the focus of undergraduate medical education to really place a more equal stress on medical knowledge and procedural skill? Or do you see it more as an addendum for students?
I'll take this one. I think nationally, we've had this conversation just recently as a Council of Deans, that nationally there is a push towards greater and earlier competencies. So do I think they're in opposition to one another? No, I think you need both. I think as somebody put it best, you know, we need to make sure when you graduate that you can fly the plane. And that means being able to keep a patient alive and keep them safe. And this is part and parcel of that experience. I think it's just another platform that allows us to do so with more efficiency.
Great, thank you. And also another question, have you taught first responders to do these kinds of procedures?
Yeah, actually, you know, I think part of the genesis of the nomenclature of our program, the Cura Collaborative, is really that it's founded on the guiding principles of Franklin as well as my alma mater at Georgetown, Cura Personalis, right? We're trying to care for that whole patient, and that doesn't end when they leave the hospital. That doesn't start when they enter the hospital doors. It's the same patient. So when we talk about trauma, of course, our patients are delivered from very difficult environments at the scene of an accident, the scene of a crime, by our pre-hospital medics and paramedics and BLS providers. So their training needs are arguably sometimes even more high acuity than when they're in our trauma bay, right? That's the patient who's in the active process of dying from a critical injury out on the street and then in an ambulance, which does not have the resources of a full-blown operating room. So they work under very challenging conditions. And we've actually been working with Phoenix Fire and their paramedics to train certain procedures that they have to do out in the field, again, in a high fidelity environment here. And one of the things we love about our program is bringing that interprofessional, interdisciplinary aspect to maximize the education in ways that weren't there before. So as an example, the firefighter paramedics have to treat a collapsed lung with a needle. They have to put that needle into the chest blindly. And if you look at the studies on that, their miss rate's about 50%. Patients are obese, it's a bumpy ambulance, they're having to kind of eyeball the anatomic landmarks, which aren't always palpable. So we brought them over. We put surgical cameras into the chest. We put a thoracoscope into the left and right chest. We blinded the paramedics to it. We've let them do the needle decompression, and then we showed them operatively, this is where your needle is inside this patient's body. You could never do that in a live patient, but now they have an ability to integrate the anatomy of what they're seeing and feeling with an operative surgical view they would never have access to in the real world. And quite frankly, that's how I learned to put in better chest tubes, was when I had a camera showing me where I was going. So bringing that to others outside of the surgical space is an obvious educational win for everyone.
But maybe you could make one comment, and maybe Jim can chime in here too, but on training faculty to do procedures they've never done before. We've had a few experiences with that already. So it's not just to train the learner to do things they haven't done. How about faculty and having them do sort of experimental procedures that they've only heard about?
Yeah, the beauty of this is that you can bring in a world expert and teach a multitude of people at the same time at no risk to the patient, because the patient's already expired. And Dr. Gillespie had this experience where Dr. Wu showed him how to do this procedure that nobody in the world has done with a robot. And then Dr. Gillespie practiced on one of these donors and then performed it on a patient who wanted to take this to 60 minutes and praise Dr. Gillespie, but he was humble enough to decline it.
Just to dovetail off of that, I think we need to talk about the benefit of also physician and provider retention. This concept of the low volume surgeon, which only was worsened by COVID. We have the ability now to get our surgeons, our faculty, those who haven't had the opportunity to be in those busy surgical experiences. We get them back on track for being an asset to the field.
Kayla, why don't you go ahead and ask one more question? We don't have any others in the chat, so let's go ahead and do that, and then we'll close up.
Perfect. So first, I just wanted to say that in the chat, I just put a link to a survey that our team has open. We would love to have your thoughts and also invite you to some future brainstorming events to help shape the future of this program. We're a small but mighty team, and we would love to have anyone's help alongside that. And for the last question, this is aimed for you, Dr. Soe-Lin. Can you talk about how the Cura Collaborative is different, and what are some of the things that are in the works with this program to really set aside from the current standard cadaveric trainings that exist across the world?
Yeah, that's a hard question to field in 2 minutes we have remaining, but I think everyone in a surgical field has participated in cadaveric training somewhere in this country once, on a weekend as part of a CME course or a sporadic course. And that typically comes at great expense. There's a lot of logistics. There's a lot of cost associated with setting up even a small, one-off course that happens once or twice a year. We certainly do it with some of our ACS accredited trauma surgical exposure courses in the country, of which we host. And, I think what differentiates this program is we're one of the few that have had the ambition to scale it and to say, well, it's not good enough to do that once a year and then expect to be great in the moment at 3 a.m. when someone's life depends on it. You have to do it again and again and again. Like any other profession, like any other sport, like any other performance, practice and repetition is key. And I think people recognize that, but they don't acknowledge that repetition is completely absent for high acuity, high risk, or low volume procedures that patients depend on. And so how do we bridge that gap? Well, you have to scale. You have to do this with repetition, and solving for the logistical and financial aspects of bringing that type of repetitive opportunity to a large volume of learners. That's the one thing that we're doing here that's not been done or tried elsewhere in this country.
Well, thank you so much to all of our presenters and our informal panel. Hopefully we got to all the questions that you had, but please reach out to anyone that's on the team. If you have further questions, or fill out that survey that Kayla shared with you so that they can get some more information that would be helpful for them moving forward. Thank you, everybody.